Pleasant greetings to all the enthusiastic postgraduates. I welcome you for this presentation of the hard and the soft tissue augmentation procedures in implants. I appreciate your learning enthusiasm and may this continue as a lifetime journey. I'm here with you from Bapuji Tendri College, Davangere, Dr. SUNITHA Naveen Shamnur here. Let's begin. We'll be learning under these outlines what are the basic principles of your hard and soft tissue regeneration. What are the treatment objectives? How do you come to your diagnosis and treatment planning? How do you execute based on the biological principles of both hard and the soft tissue? What are the emerging trends and the scientifically backed up techniques that are used? Now, all of us are aware that the proprioception is what leads the bone to maintain its height and the volume. So with the loss of the tooth or the teeth, there is a gradual degradation of this bone, both qualitatively and quantitatively. 25% of the bone is lost during the initial first year, and 60% of the bone is lost in the subsequent third years. The resulting rich deficiency, what is seen, makes it impossible for us to proceed with not giving an aesthetically predictable outcome, replacing the tooth back in its original position. So it's mandatory that you need to have augmentative procedures in check to give a more aesthetic outcome. Both the hard and the soft tissue, even though we have theoretically categorized as different augmentation procedures, they work synergistically. There is no way that you can just do away with the soft tissue, ignoring your hard tissue. The picture here depicts, even though a soft tissue loss, the underlying bone here, when there is a resorption, exposing your implant threads, that means there is a deficient bone quality that has led to the subsequent bone loss. So please remember, it's always a synergistic approach and never a one-sided outcome. What are the main principles of our alveolar bone regeneration? First and foremost, you have to learn that the placement of any of the bone graft materials, they just favor the healing process in these osseous defects. And you're going to learn about the different osseous defects because it can be a one-wall defect or a two-wall defect, a vertical or a horizontal. And what are the factors that assist in your hard tissue regeneration is, we call it as a PASST principle. That is, the first one being your primary wound closure. Maintain that you should have a passive, there should be a tension-free wound closure. People who have done with the flap release, you know that sometimes you will have to go on to your periosteal scarring to have a tension-free approximation of the ridge defect after the augmentation. Thereby, with the passive closure, you are reducing the amount of the membrane exposure, the wound contraction, and also you're enhancing the proliferation and the differentiation of the cells to have a neovascularization set in place. Doing all this, you have the initial wound stability, thereby you can have a predictable result. So these are the principles where you have a cell exclusion. When you're doing with a hard tissue augmentation, it's imperative that you have a membrane set in place because you do not want the epithelial cells or the fibroblasts coming onto your hard tissue, thereby giving a more of a fibrous integration rather than a osteoconduction. And the space which is created beneath the membrane completely isolates the defect. Okay, and it also serves as a scaffolding. We have the various scaffold membranes that we'll be learning in the further slides. And you need to protect the clot. The initial clot stabilization is very, very important. So the treatment objectives is very simple. You need to establish a sufficient bone quality and quantity for the safe and the predictable implant success. Now, what happens during our diagnosis and the treatment planning? In general, there are no absolute contraindications for our hard and soft tissue augmentation. This is, I'm speaking from the point of view that you have done the initial treatment, the diagnosis part for the general implant therapy, where you've eliminated all the systemic conditions and you've gone ahead with the patient's noxious habits and therefore. For the augmentation, make sure that the patient is physically fit enough to withstand any of the major or the minor surgical procedures that is done, be it the harvesting of the bone or be it the use of your PRF. That's the only thing that you need to bear in mind. And we always believe in the retrospective treatment planning. So subjecting the patient to a 3D image as a CBCT is mandatory like any other implant procedures. So let's come to the basic question. What is grafting? What kind of grafting do we need? What are the different graft materials that are available? And when do we do the grafting? And if at all the grafting is done, when do I start with the implant placement? So let's address these questions. Okay. Now, all of you are basically well aware of the various ridge defects. The basic being your seabirds, where he has given us class 1, class 2, class 3. Simple. Class 1 is a horizontal deficiency, class 2 is a vertical deficiency, and class 3 is an amalgamation of both hard and the soft. You have one more by the Hammerley and Jung. This is for your fresh extraction sockets. This is based on the amount of your buccal volume, the buccal plate thickness, and the presence of the buccal plate. Class 1, where you have a fresh extraction socket that has got a very good buccal volume, at least of about 3 millimeters of your buccal plate. And class 2, you have a dehiscence or a fenestration of the buccal wall after the tooth extraction. And class 3, there's a large dehiscence or there can be an absolute loss of the buccal plate. Now, this we are speaking post the graft rationally. So assessing the kind of the defect that you are working with gives you a better understanding as to what kind of augmentation, what is a different graft material that you're going to need to handle this case. With the hard tissue comes obviously the soft tissue, gingival biotype. We call it as either a thin or the thick. Basically, easily assess chairside using a periodontal probe if there is when you can see the translucency of your periodontal probe, that is called as a thin, and if you do not, that's a thick. Thin gingiva, please remember, it is most friable and very easily it cannot bear the abrasive action of either your foot or even your brushing techniques. So we need a thick biotype. And when I say the phenotype, thick gingival biotype, with a good amount of the buccal cortical plate is the best thing that you can go ahead with your implant augmentation procedures. And there's one more classification as given by Cologne, same as we call it as a CCARD, based again as horizontal combined or vertical. This is given as a conjunction with your maxillary sinus defect and whether you need to go ahead with the indirect sinus lift or a direct sinus lift procedures. Okay, what leads to the success of the implant? It's three main things: hard tissue, soft tissue. And both when the hard tissue and the soft tissue are taken care of, it leads to a predictable aesthetic outcome, which directly gives you a good prognosis for your implant. As you know, Salama said the statement that bone sets the tone, but the tissue is always the issue. You take care of the soft tissue, then automatically you are halfway there, and then you have a predictable outcome. When I say aesthetics, what exactly are we talking about here? Always, as a prosthodontist, we believe in the retrospective treatment planning or the crown down approach. Basically, you're going to evaluate the implant position, Of course, in the three-dimensional aspects, the amount of the facial bone that I've already discussed, the form and the shape of the restoration, whether it's an anterior or a posterior, and the quality and the quantity of the peri-implant soft tissue. So this gives you the aesthetics. This can be screened either as a pink aesthetic score or a white aesthetic score, or both called as a pink and a white aesthetics score as given by Miller. So what other goals you need to bear in mind? You need to have a good firm mucosal support around the implant. There should be no seepage. There should be a nice long junction epithelial connection there. And with this leads to a maintenance of your crestal bone support and a better aesthetics. Now, before I go into detail about the soft tissue, you should appreciate the difference between what is the main difference between your periodontal ligament and the implant supported restoration. What role has your keratinized mucosa? What role has your attached mucosa to do here? Basically, the biology of both is simple. Only that in the periodontium, in the implant supported mucosa, you have more of a collagen, type 1 collagen, whereas in the periodontium, you have collagen type 1, type 3, and type 5. And also, we have fewer fibroblasts in our periodontium as opposed to our we have a fewer fibroblasts in the implant supported mucosa as opposed to our periodontium. And the peri-implant mucosa here resembles the scar tissue without having the supracrestal fibers insertion into the cementum. Please remember this. And obviously, there is a less vascularization in the peri-implant mucosa as opposed to a periodontal ligament. Yes, all this has a direct bearing on how you want to create the permucosal seal around the implants. Having said this, the importance of the keratinized gingiva is debated. Few authors have said that we absolutely do not need the band of the keratinized gingiva, but we have the authors' studies from 1972 till 2002 by Lang and Low, the Maynard and the Wilson, and the Warren and the Boozer, and the recent being Azzi. They have reiterated that having a good band of the keratinized gingiva around the implants is mandatory to have the good seal or the permucosal seal around the implants, which prevents the abrasive action of either being the muzzle action or even your brushing action. So when do you want to start with your soft tissue augmentation? Either during the implant placement or during your implant placement second stage or after restoration or during the maintenance phase. Let me tell you here, there is no timeline as such that at the time of the surgery till you have the maintenance phase after 5 years or 10 years, the soft tissue is going to remain the same. There are 8 changes that cannot be negated by anyone. But having said this, it is always preferred that you time the soft tissue augmentation at least during the second stage of your implant uncovering. If you're doing it after the restoration, there's always a patient morbidity factor or even the patient trust issues that why this procedure is being done when I'm already here mentally to receive just the crown and walk out of the clinic. I do not want any kind of trauma being done to me at this stage. And also, it is difficult to assess the volume of the soft tissue that you want to give at the time of the delivery of your implant crown. So, it's best to be done at the time of your implant or before the implant placement if we are doing it as a 2-stage soft tissue augmentation, later followed by the hard tissue augmentation, or you can do it always at the time of your implant uncovering, but never ever after the restoration. Now we have a simple flowchart given here as to when do you want to do this. You have step 1 and step 2 and step 3. The basic rationale here is quantifying the amount of the keratinized mucosa, less than 2 ml or greater than 2 ml. That sets the tone for your step 2 and step 3. And for a hard tissue, we know that maxillary bone is quite different from a mandibular bone. Maxillary bone is more cancellous in nature, and mandibular bone is more cortical in nature. So if you follow this defect flow chart based on whether you're working with a vertical defect or a horizontal defect, there are various augmentation treatment options given, whether being a simple interpositional bone graft or a split ridge expansion for the maxillary, and for the mandibular, you can go in for a guided bone regeneration. At this point, I want to tell you that the distraction osteogenesis that has been given here in the flow chart we no longer follow, because we have the better, more predictable guided bone regeneration techniques that has been scientifically validated. Now, this is I've already discussed this before. Why is it important? Now, you can make a note of all the articles that are given here as to why the soft tissue health is important, and it's affected by the thickness, the amount of the tissues, amount of the bone, and of course, the implant distance, that is 3 mm, as given by Tarnow, the distance between the contact area of the clinical crown and the crestal bone. If it is less than 5 mm, obviously there will be 100% chance of the interdental coverage with the papilla formation. Mucosal thickness. How do you assess the mucosal thickness? Best is by using your tissue mapping procedures. Greater than 3.5 mm is always mandatory. And if there is less than that, a black triangle which is seen in the anterior restoration, it's quite difficult to treat. So please assess the biotype and always augment it with the soft tissue procedures, and then follow it up with your interim restorations to get a papilla coverage. Biologic width, I have told you, there is a difference in both the unloaded and the loaded implant conditions. And there is also a difference between the one-piece and the two-piece implants. Okay? Okay. Now let's start with the various procedures and the materials that are used for our soft tissue augmentation. Now, I'm here theoretically categorizing as soft tissue and hard tissue, but when it comes to the practical aspect, you should be aware that both go synergistically. All right. If I'm doing a soft tissue, it means that you've already evaluated the hard tissue and then you have proceeded with the soft tissue, because soft tissue you need to have a passive closure. Remember, I have told this in the earlier slides where we talked about the PASST principle. So the different graft or the materials that are available is a gold standard, autogenous, or the pregingival, of course, a connective tissue graft that is derived from the patient. It's a gold standard. And the disadvantage of using these autogenous grafts is the size, the quantity that is available, and sometimes the quality also. So to negate this, we have the allografts and the xenograft materials. And the numerous companies that are available for your xenograft is called as your from the Geislich company. That is one, and the Newer Cross it's a Switzerland-based company, so you can use these. Okay, coming to a free gingival graft. It's harvested from the palatal area. And if you're harvesting from the palatal area, let me add a note that you should know as to where you have your palatine nerves and your blood vessels, because you're harvesting at an angulation of 90 degrees from 6 mm away from the free gingival margin from the palatal aspect. And then you're going for a split tissue thickness release, and then you're going to harvest the connective tissue. The advantage here being, it is reliable since it is from the patient's own donor site. It has got a predictable success rate. But the disadvantage is you cannot use it in conditions where the patient has got a very high smile line. There is a definitive, the color discrepancy. It is seen more like a patch. Since it's a connective tissue, you'll see more like a white patch that might be unacceptable to certain patients. And if this is not possible, if you see that it's in a high aesthetic area, what is the other approach? You have to start with the tunnel approach. I'll be discussing it in the further slides. The connective tissue graft. This overcomes the aesthetic drawback of my pre-gingival graft. You have a good color match and also has a good vascularity. And the drawback is only being the morbidity and the lack of the adequate tissue in case of a large defect. Can you see here? Even though we have harvested it from the palatal area, you're going to use a tunnel-based approach here. And this is the rich defect that can be used for your connective tissue is a very small size defect. You cannot use for a large scale because obviously there is not of abundant tissue in the palatal area that you can harvest, given the condition that even though you can harvest it bilaterally, there is always a negative or the drawback due to the patient's morbidity. Of course, this is the tunneling approach that we follow. As easy that it looks or as predictable that it may sound, if this is not done properly, it requires a high skill. Please remember this tunneling is a very sensitive and a skill-based procedure here. And you need a specific kind of instruments, which we call it as a Vista instruments, given by your Hyosung company or even given by your Osam company. And recently, even the GDC people have introduced the tunneling instruments. You have to use these instruments because they have only a one-sided sharp end, the other side becomes blunt. The way it approaches the soft tissue, it does not make a cut leading to a scar formation there. So this is one of the very good treatment approaches that we can use to increase the connective tissue outcome around a single or at least 2 implant site procedures. Now we have one more. This is called as a poncho lamina graft. This is used for a single implant site, which is performed through a one-step, we call it as a one-step optimization process called as a OSO, where you use a cortical membrane, being a soft lamina. Here it is given by the Technos company, the trade name being your osteobiol. And this is very easy. At the time of your second stage, that is the implant uncovering, you can use this graft and then you can customize it and you can create a nice emergence profile. Thereby, you are not going for a second stage augmentation procedure. So this is also widely used for only a single implant placement and not for a multiple implant placement, because multiple implant placement, again, you have to create the emergence profile and the papilla. Okay. Okay, now we come here to the minimally invasive rolling flap. This was given by Miller. Now here, we are going to use a 1 mm of the round burr to de-epithelize the area. You need to remove all the epithelial cells from the donor site. And you're going to give an incision lingual to the crestal bone. If you observe here, my incision is way lingual to the crestal bone. And you can have a minimal horizontal releasing incisions. And after the implant placement, you just have to roll in, creating kind of an envelope and tuck in onto the labial side. And you have to secure it with a good suture. So what happens is you have a good soft tissue volume around the buccal or the facial surface. Thereby, you're creating a beautiful emergence profile. Now, once we have done all the soft tissue augmentation procedures, we are now proceeding with the hard tissue. Hard tissue, what is my rationale? Have a good function, aesthetics, thereby leading to my prognosis. What are the different procedures? As scientifically documented, you have the ridge preservation techniques, that is in situ before even you begin with the extraction procedure. Now you have bone regeneration in the fresh extraction sockets. You have a horizontal, vertical, and of course you have your grid split. Now let's start with the basic one, where we talk about the minimal traumatic extraction. This is a conventional socket grafting. You need to have, during extraction, most of the time we use our elevators to expand the buccal cortical plate and then use our elevators to remove the tooth. So there is a slight change the technique here. Without causing any expansion of the buccal cortical plate, you need to remove the tooth or beat your root fragment. Thereby, you're maintaining the volume of the soft tissue there. Okay, and immediately following the removal of the fragment, you're going to simultaneously graft the extraction socket. Okay, the best being your combination of your allograft or your autograft, and then secure it with a collagen plug. There will be a amount on the certain degree of the loss of the bone, but as compared to a no grafting situation, this is always a better situation to handle. Now, how do we go about? Obviously, after the tooth removal, you want to create a nice bed for the for the osseous regeneration. So you need to deprive free of the granulation tissue. Then you need to induce a fresh bleeding into the socket. Either use your curettes or any of the rotary instruments, and then visualize it thoroughly with the help of your periodontal probe, and then go ahead and place your graft materials. There's one more. In the non-aesthetic area, how do you want to do? You can give a high density PTFA membranes or a cytoplasm membrane and follow it up with your hard tissue grafting procedures. Now remember, before this, I've already talked about what kind of extraction socket that you're talking about, whether it's where there is a complete fenestration of the dehiscence of the buccal wall, or there is an complete intact of the buccal wall. Only in cases where you have an intact buccal wall, all these procedures, all the augmentation procedures that I've discussed till now holds good. If there is a loss of the buccal bone, no, you cannot do this procedure. We will have to start with the horizontal bone augmentation procedure. And leukocyte platelet-rich fibrin has been widely used now because of its regenerative potential. Okay, so that becomes the first line of defense as opposed to using a cytoplasm membrane or even your PTFE membranes. So KARNATAKA in 2001 gave the 5 diagnostic keys if you're working in the aesthetic zone, based on the defect as mild, moderate, and severe, and also dependent on your labial plate and what treatment you need to go and the time to place the implants, whether it's a mild to a severe. Now we discussed this simple scenario. You have an intact buccal, so please go ahead with the allograft, follow it up with a free gingival graft, and use a membrane to approximate the extraction wound. Second would be your root membrane technique. What is a root membrane technique? This is also called as your socket shield technique or SYN technique, partial extraction therapy or a root submergence technique. Okay. So basically here, this was given by Howard Gluckman, and this has been the most widely used and most scientifically backed up procedures whenever you're working in an aesthetic area. Now, when a tooth is indicated for extraction, I'm not going to enumerate the reasons here. You're going to subject the patient to a CBCT, and when the CBCT finding gives you an indication of at least of 3 mm of your buccal plate volume, then you would want to create a thin sliver of the fragment of the labial part of your tooth. And how do I do that? We have a special instrument kit either from Bredent or from your Brasseler company, where they give a thin pointed long fissure burst, and you start reducing, you section the tooth and you leave only a thin sliver opposing to your buccal plate, and then you create a purchase point parallel to the fragment with a round burr. So now you have your implant placement much parallel to the labial sliver of your tooth that is left behind. And you have an amount of space that is created between the tooth fragment and the implant that you're going to place. Now, this jumping distance between the two is grafted well. And then you're going to follow up with any of the soft tissue procedures that I already discussed, either with your rolling by the millers. So the added advantage of this is there is a proper approximation of your labial plate, thereby leading to a nice emergence profile. Now, in cases where you have a reduced ridge volume on the horizontal, Tatum, that is a Hilt Tatum, he gave the concept of ridge splitting. The protocol was set almost in the 1970s. Earlier, it was done with the osteotomes. Now we would go ahead with our piezo surgical instruments. So, what are the indications? You have a narrow ridge where you have a less of 2 mm of your thickness of your buccal cortical plate, and you should also have an adequate marrow component. The marrow component is a key here. If you do not have an adequate marrow component, then please do not try to do a ridge split. It's going to result in the tissue necrosis and a big failure. And you should also have a vertical height of at least 10 mm to start with this. So if you're working with a single side, no, this is not a procedure to be followed. If you're having a less than a 2 mm of width, again, this is not the technique to be used. If you have a concavity or undercuts of the ridge, please do not use this ridge splitting technique. So these are the key points that was given by Tatum, and again, it is reiterated by Lussman and Levenstein in 1995. Ridge expansion in the maxillary has got more predictable outcome as compared to your mandibular, obviously because of the cancellous nature of the bone. And it also includes, you have to take care of your, the interocclusal space and the biomechanical force factors, especially the parafunction. And, this technique is more suitable for your maxillary as opposed to your mandibular, because mandibular leads to more tissue morbidity. So better would be for the maxillary. This is how it would look. Instead of using an osteotomes, we would, or a mallet, you have the mallet also, but that was gruesome to the patient back then. But with the piezo surgery, beautifully done. You raise a flap, a full thickness flap, both from the facial as well as the lingual. You use the piezo surgery to create first a crestal incision, then you have a wide horizontal releasing incisions given. You have the gradation of your reamers that is required to create a split between the buccal and the labial cortical plate, at least of about 2 to 3 millimeters of the split that you're going to create. Then you're going to graft the site with preferably autogenous with mixed with the xenograft in a percentage of 70 to 30. Remember, more autogenous bone graft, more would be the osteoinductive and the osteoconducive properties. Then you're going to have a bone tack screws in place and then follow it up with the soft tissue closure. So this is how a ridge split technique is followed. Next comes a beautiful, the Corey technique. This is also called as a shell technique or a split bone technique. The basic rationale here is we are going to use an intraoral grafting. And where do we harvest this grafting? It is harvested as a thin video graft from the mandibular ramus area. Okay, we are going to harvest it from the thin as a sliver from the ramus area using our piezo surgery instruments and not with any burrs. Okay, it is created, it is decorticated, shaped to the defect that you're going to place. You can see both in the maxillary and the mandibular arch. Once you have decorticated enough, you're going to stabilize it with the bone screws. These are 1 mm in width but 10 mm in length. You have a special hand-guided instruments that is that is used to keep in place. Okay, then the gap between these two plates is now filled with your graft materials. Again, a combination more of the autogenous allograft and then a portion of your xenograft. Wherever we want volumetric, which is more greater, then we have a combination of coarser particles to the finer particles. So the autogenous graft here acts as a finer particle, and the coarser particles is usually your xenograft. We need a combination of both to condense or pack into these, the volumetric deficiency that has been created. The main advantage of this is it does have a predictable stability, provided you know that you have stabilized both these plates, the video grafts, properly, and there is no, what should I say? The donor graft also is more, better to receive this harvestation. And you should also have a proper soft tissue approximation. So here comes a need, whether you want to go in for a soft tissue augmentation to have a better volume of the soft tissue to augment this quantitative bone augmentation, or you want to do it simultaneously. And there is some amount of periostal scarring that I have seen in my cases where I've used the Cori technique. Cori technique can be used along with your sticky bone also, but I think I'll be talking about the sticky bone in the further slides. Okay. Okay. This is a sticky bone. This is autogenous biomaterial, and where it uses a particulate bone graft material with the patient's own platelet-rich fibrin, which we call it as a PRF. Now we have PRF, IPRF, LPRF. This is based on what kind of bone morphogenic proteins you need, or what kind of cell sensors that you need to create the osteoinductive potential there. So when you use the sticky bone, which is it creates enhanced growth potential, where it releases the growth potential cells, and when augmented with a horizontal bone defect, you have a more predictable outcome. So here we derive about 20 to 40 ml of the blood from the patient. Then you subject to the centrifugation. Then you have the PRF there. You have the graft material that has been, again, a combination of your allograft and the autogenous graft. You mix it in the proportion of 60 to 40 or 70 to 30, depending on the site that you want to augment. Then this forms a nice of a sticky mass, a sticky mass because of the PRF, the platelet, more of a fibrin gel. And this allows for the easy condensation into your bone defect. Now again, a little note on the mandibular ridge split technique using your piezo surgery and not with a piezo osteotomes. Here, a controlled green stick fracture, the controlled green stick fracture of less than 2 millimeters is done. Then you have an exposure and the lateral repositioning of your buccal wall. Then you have an intrabony defect which is created, and it is filled simultaneously with your, graft material, and you approximate with a membrane, and then you have a passive closure. This is also one of the predictable outcomes, but better done using a piezo surgery. Now we have learned about the different augmentation techniques and what are the different techniques that is there. So when do you want to place the implants, or do you have a question that place it immediately following the augmentation or after the augmentation? For this, you have a nice chart given here. If you're doing a horizontal augmentation for the maxilla, minimum of 4 months is mandatory for the turnover of your bone graft into your native bone. 4 to 5 months or even 5 to 6 months is beautiful. It's the result what you get is very predictable. And if you've done a vertical augmentation of 5 months, both either be it in the maxilla or the mandible, it's mandatory. And always a gold standard is the autogenous bone grafting. Now we have the dentin bone graft that can be used. Okay. But having said this, there's always a disadvantage because of the volume that can be harvested. So always use in a higher ratio, if at all that's possible. This is one case where we have used titanium mesh. Of late, we have a titanium mesh reinforced membranes. Earlier, we used to use this titanium mesh, and the only morbidity that we used to face was the exposure of the soft tissue overlying this. So, one more key factor when you're using this titanium mesh is it should not go on to your adjacent native bone. You should keep it secured only to the graft area. Okay, that was one of the things. And how do I design this titanium mesh? You have the CBCT. So you're going to have a 3D printed model of the defect area. Then you're going to customize it and contour your titanium mesh or even your titanium reinforced membrane, trim it and have it in place. Then you need to secure with your bone tack instruments, and then you are set for your augmentation procedure. This is how it looks, and it is grafted with your RHBMP bone morphogenic protein here. Again, the advantage is it improves your hemostatic function, and it is effective in preventing the the fibroblast proliferation. Thereby, the new connective tissue attachment is limited only onto your soft tissue attachment. And it has got a beautiful strength. Even in a thickness of 0.1, you have a beautiful strength. That is what is required to keep the bone graft stable enough till it converts into your native bone. So what did we learn from all this? The 5 keys are the incision design. Please remember the incision design and the flap management is crucial. Let's say incision. You are going to use a micro, what we call that as, a 15C blade. And the incision is always minimal incision, papilla sparing incision, and it's always a clavicular or a sulcular incision. And remember, based on the attachment of your keratinized mucosa, you need to design your incisions. If there is a less amount of keratinized mucosa, you're going to go more cervical, more horizontally releasing as you go towards the apical part of the tooth. And always, whenever you have the site, prepare your site properly so that there is enough of the angiogenesis. So decortication adjacent to the implant residual bed is mandatory. You have to have a proper space maintenance by having appropriate membranes, either your PTFE membrane, titanium reinforced membrane, or even your titanium mesh. Stabilize it well with enough of your bone tack screws and also with your sutures, both hard and soft tissues. This is very crucial. That's why we do a double closure or a triple closure sometimes. And all these has to be attention free. Okay. So what are the therapies? We are talking about the membrane, the barriers here, okay? What kind of barrier membranes? There are 5 factors, again, the biocompatibility, the cell occlusive properties, the integration with the host tissue, and the ability to create the space, and definitely the clinical management. Because this the easiest one is your PTFE, okay? It's a non-degradable, and you need to have a second surgical intervention to remove the membrane. This is one of the disadvantage. The other resorbable membranes are, basically synthetic, and if you're going for the natural, it's always a collagen membrane. The resorbable includes your polyglycolic or the vitral mesh or the polylactide. Okay, these are available with your BioOS, the Gaslich company. Basically, the advantage of using these grafts is it's available in the various sizes. You can cut, shape to the defect that you're working with. How do you make the choice of the graft membrane? Basically, the amount of the bone regeneration that is needed, the space making and how long you want, depending if you're using more of vertical augmentation combined with the horizontal. That means, as I said, remember in that uh, timetable, at least about 5 months. 5 months, sorry. So till the 5 months, you need to have the membrane set in place so that there is no proliferation of your fibroblasts or the epithelial cells. So you need to have choose the membranes accordingly. So these are the descriptions that you need to know about what kind of bone graft and what is the property that they possess, being the conducive, inducive, or a combined. This we have already discussed. So if you want to harvest the autogenous, which we always call it as a gold standard, but remember it's got its own morbidity. In the maxilla, it's always a tuberosity, or the symphysis area, or the ramus. The ramus area, and extraoral, you can harvest it from the rib, tibia, and the iliac crest, provided the patient is systemically good enough to sustain these. Only then you're going to proceed. Autogenous, I've told you, it's a gold standard. The allografts, there is always a risk of the antigenicity, okay? So choose wisely. And xenograft, it's even though these are deproteinized, they are more of a porcine or a bovine origin in region. So it's good, and you can use it without any immunogenic reactions. And where do I use this xenograft? When I want to maintain the volume, the bulk volume, I'm going to use my xenograft. Alloplast, synthetically produced, you have either your coralline hydroxyapatite, which has got a better physical properties because of its malleability, combination of your calcium phosphates. Okay, like I've already mentioned earlier, the choice of the material depends mainly on your augmentative procedures. And the use of always a xenograft has got a lower rate of resorption as compared to your other, thereby you have the volume that can be saved up to the 5 months till the conversion happens. For the ridge preservation, obviously, these are the important structural changes that eventually happens after the loss of the tooth. So for any guided bone regeneration, you need to know that you have to use a combination of resorbable, non-resorbable, and you can use a bone substitute alone or bone substitutes in combination with your soft tissue. 63% of the vertical bone loss happens in the first 11 months of your tooth extraction. It is reiterated by Tan with a study in 2012. Okay. So simple procedures, I'm just giving you more of a pictorial representation here, what happens with the horizontal and the vertical bone loss. If you don't place an implant, following an augmentation, how it appears at the end of 5 months. It's a freshly extraction socket. Can you see the amount of the good buccal and the lingual bone? They're beautiful. You place it in the ideal 3D positioning. The implant is placed in the ideal 3D positioning. Here, it's a central fossa, and the jumping distance between the buccal bone and the implant is grafted. You can use a allograft or a xenograft here. Then you can close it with a collagen membrane, and you're good to go. This is how horizontal augmentation looks, where I've harvested a veneer graft, stabilized it with my bone tack screws. I've also done a little bit of ridge expansion there, grafted, closure, and see the amount of the good vertical bone that I have received after 5 months. I'm going to remove my bone tack screws later, then go ahead with my implant placement with obviously my guided surgical guide. And it's a simple one, class 2 Siebert classification. If I have a dehiscence, simple dehiscence up to the middle 1/3, I would just use a combination of my autogenous or a xenograft, closure with a membrane, and good to go. Ridge splitting, yeah, this was the distraction or ostrigen, the ridge split instruments, which we call it as a controlled green stick fracture. more used in the maxillary anterior and posterior, where you have a type 3 or type 4 bone only, and not at all in type 1. Okay. If you're doing a vertical ridge augmentation, you can use only bone graft or a distraction osteogenesis or a ridge split. Now, does the abutment really qualify? Yes, titanium has always been used as gold standard for its well-documented biocompatibility and mechanical. But Abrahamson, he analyzed the soft tissue and said that titanium and ceramic abutments, they promote a good, even gold for that matter, promotes a good soft tissue attachment. Oh, I'm sorry. Whereas the gold alloy and the porcelain, they fail to promote a good soft tissue attachment. But microbiologically, they found no difference. But I think still we are going ahead with the titanium and the more recent being zirconia implant materials. Crest module and the abutment design. Obviously, we all now do the platform switching or the more stable connections. So the main the biomechanical principle here would be to dissipate the stress away from the crest of the implant bone. And the hypothesis here was a change of the shear force to a compressive force, as you know, with the Jung studies in 1996. Okay, even the laser lock implant surface laser treatment reduces the crestal bone loss by 0.59 millimeter or less than a millimeter, I should say. And how do I corroborate after all my the hard and the soft tissue procedures is I call it a success when I corroborate with my pink and the white aesthetic score. Okay, there are 5 parameters that has to be used and graded according to this score. So that will give me the aesthetic outcome and obviously my clinical outcome. So to summarize, what are the techniques? You have a full thickness soft tissue only, the pouch, the roll technique, the modified papilla or the interpositional graft, the Palachi technique, the subepithelial connective tissue, which is also known as a Langer's method. For your, you have the full thickness soft tissue only graft by given by Metzer, Siebert. The technologies are emerging on day-to-day level with more of emerging techniques and the instruments. We always have a constant upgradation of our materials. Thereby, you need to upgrade your surgical skills as well. I shortly summarized the procedures, but what you need to have is a thorough tactile sense or a feel of the soft tissue, the handling of the soft tissue, the handling of your hard tissue, how to create a cut, how to stabilize your membrane, how to use your sutures. All these is to be done to create a microvascularization. So if you are adept, go ahead. Very good. Do it on your own. Otherwise, please have a team approach and obviously do it for the betterment of your patient. There is a widespread use of the growth factors here and growth factors here, the scaffold membranes, and how we use the 3D application models here. If you have a deficient ridge, we use rapid prototyping to create the to create the 3D printed model and then custom fit into the defect. Okay. In general, all the augmentation procedures that I have discussed till date are scientifically validated and also they are predictable. But it also depends on the skill of the clinician who is handling it. So the correct selection, the knowledge is mandatory. So currently the research in the field of advanced bone grafting is directed at overcoming the technical and the biological limitations that continue to challenge our implant industry. There are a few other things that I've omitted here regarding how do you use the PRF, how do you stabilize the PRF, the detailed procedure of the soft tissue and the hard tissue. That is beyond the scope of this presentation for me to tell you. And I wish you a very happy and enthusiastic learning curve ahead. For your examination point of view, it's either asked as a one of the techniques, either the Cori technique or be it your sticky bone graft. How do you use it? Vertical augmentation or a horizontal augmentation, or be it your membranes, part by part, they might ask. But set aside the examination protocol. Whatever you have learned today will serve as a fundamental for your future implant procedures that you'll be doing clinically. Thank you so much. Have all of you have a pleasant learning experience. Thank you, and a big gratitude for the organizing committee members. Thank you for this opportunity.